Bismillahir Rahmanir Rahim. Can I have your attention, please? We are going to start ACO plenary session named lectures. There are 6 very prominent people, speakers, teachers, researchers, masters in their own fields. In no particular order, we are going to request them to come over to the rostrum and read out their very prestigious lectures, like Professor Raja Mumtaz Award, Professor Sayyid Ramzan Ali, and some others. There is a little bit of alteration in the list on request of one of the speakers. He has got to go somewhere else, and first of all, I'm going to request Mr. Abdullah Al-Qatani from Saudi Arabia to come on the rostrum, and his topic of interest is application of vitrectomy in ocular oncology. Please.
Dear Chair and panelist, audience, it's a great pleasure to be part of this prestigious meeting, and it's a great pleasure also to visit Pakistan for my first time, which is considered as second home at the same time. So building on the request of the chair to start my biography, even though I don't think it's very important, but if I'm obligated to say it, I'm the chair of the ophthalmology in King Abdulaziz Medical City, assistant professor in King Saud University for Health Science. I did my residency in Paris, and I did my first fellowship, which is surgical retina in Paris, also ocular oncology as a second fellowship in Paris. So I came back to my Saudi Arabia 2013. Then from that time to now, I'm working in the King Abdulaziz Medical City. So my talk is about application of vitrectomy in ocular oncology. In the past, we was not able to use vitrectomy in many places. But nowadays, with the improvement in the vitrectomy itself, we have a lot of improvement that facilitate using this technology in many things. And the reason for that the vitrectomy itself becomes safer with the high cut, with the less traction on the retina, and it's become faster, it's become easier with a small port, and with the less leakage post-sclerotomy. So this is why the use of this technology has been familiar with many things, like CRVO, BRVO, diabetic macular edema in some cases, and one of those applications is the ocular oncology. So there is 2 parts of using the machine for the ocular oncology. Number 1 is the diagnostic part, and the second part is the treatment or the management part. So lymphoma is one of those well-known disease that the main diagnostic reason way for it is only by diagnostic vitrectomy. You can have some sort of screening like IL-10, IL-6 ratio, but the main core for management, for diagnostic, it should be vitrectomy. It's a simple vitrectomy like any type of vitrectomy, pars plana, in which you should respect some procedure in it and some tricks, like the infusion has to be closed to avoid having a diluted material. And 1 ml at least of the pure vitreous should be sent to a lab to be centrifuged, then analyzed by the pathology. And the idea here is you have to connect it to the handpiece. With the old machine, the connection between the handpiece and the syringe, it takes 80 centimeter or 1 meter, which is far away. Nowadays, most of the vitrectomy machines have a special connection just close to the handpiece, maybe 8 to 10 centimeter away from the handpiece itself, which facilitate this maneuver. So specimens sent directly to the cytology and pathological lab, in which after centrifuge, you should get 1 to 2 vitreous slide, which will be very helpful for diagnosis. Whenever you finish the closure or the core of the vitrectomy, you should open the infusion. Then at that time you will get a diluted vitreous. And the idea is to avoid the collapse of the eye. You should open the infusion, whether by fluid or by gas, whatever you like. The idea is the diluted specimen after that. You can send it for culture or a BCR if you want. Cytokine dosage is one of the parameters of diagnostic of the lymphoma. And this is done by usually IL-10, IL-6 ratio. In the past, it was only the IL-10 which is important. Now IL-10, IL-6 is a very important. Clonality study or the gene rearrangement also is very important for knowing the type of the disease or the type of the cytocells that cause the tumor. Some of the advice, if you are using the 20 gauge or 23 gauge, 25 gauge or 27 gauge, you will find that 5 ml syringe is one of the best. Sometimes you may use the 10 if you have a long tube connection like 80 centimeter in some of the machine, which become less and less with time. So your assistant is going to connect it here, as you see here. So the assistant will be collected in a purely vitreous without infusion. So I see the video. I think it's not working here, but the idea is to pull 1 ml of the specimen to take it to the pathological lab. This is one of our study that published with the work in Paris, BTSL Hospital and Institute Curie. It talked about the parameters that needed to reach a diagnosis, which is not easy to reach a diagnosis. You should know that the delay of diagnosis to be achieved for lymphoma is at least 6 months. So it's not easy to diagnose because it's resembling in most of the time the uveitis. The second part is the melanoma, which is we use the vitrectomy for managing the complication of the melanoma itself. As you may know, the melanoma is treated by radiotherapy or brachytherapy, and after that you will leave a mass, which is a huge mass, gonna be ischemic, secreting VEGF, not enough to be treated by the anti-VEGF, so removing all the tumor that has been ischemic with the endoresection is used for this cases. The tumor has to have a criteria to be used and to fit in that category for endoresection. It has to be between 10 and 15 millimeter. So it has to be big enough to justify using the endoresection, and it has to be not big enough to justify the inoculation itself. So it has to be between a 10 and 15 diameter. Thickness should be justified by at least more than 5 millimeter to have a mass also to be removed. Some people do that before the brachytherapy or the radiotherapy, and some people do it before. The majority of the people all over the world do it after. Few people do it even before because they don't think this maneuver can cause metastasis. So this is one of the controversial diagnoses. The endoresection is, as you see here, this has been treated by the radiotherapy. So the idea is to remove this big mass and to reach the sclera itself. The sclera is a white color, and whenever you get this shiny reflection of light, you know you reached your goal. You have to remove all the area. Endolaser around the tumor is a controversial because sometimes whenever you reach this normal area, which is the safe area that you have circumscribed by a laser, you can eat it itself. So there is no really strict on it. This study also, it showed that the main cause, this study done in BTSL, in Institute Curie actually, with Madame Desjardins and Madame Nathalie Cassou, and it showed that the main cause of removing the eye after the inoculation is the neovascular glaucoma, because you leave a big mass of ischemic cells that can cause neovascular glaucoma later on. And this is why the people, whenever they try the anti-VEGF as a management for those, they inject many anti-VEGF, which was not enough to calm the secretion and to calm the neovascular glaucoma. And doing a lot of anti-VEGF could be a treatment, but it's not practical in those cases. it shows you that doing the endoresection can decrease the risk of removing the eye because of neovascular glaucoma by 82%, which is a huge success for this maneuver. The other things is using the 25 gauge or 27 gauge as a replacing for the fine needle aspiration. Sometimes when you need to get a sample, you need to put the fine needle aspiration, suck some cells, send it to the lab, which is not easy for the lab to find it. And this is why some people with the fine needle aspiration, what they do, they put it inside the tumor, in and out, just to detach some cells. And doing this sucking with the vitrectomy will save time and will help reaching the diagnosis. So I will show you here one of the way that you need to get a big mass in which the 25 needle or a fine needle is not enough, and we will show you also how we manage the complication that's happen sometimes if you go through a small port. So this is a suspicious lesion on the retina, and you circumscribed the area with a laser. Then after that, you go with a vertical scissor, which is a very helpful tools in dissecting the retina and cut it. And you can control bleeding in those cases, which is very common, either by laser or by increasing the intraocular pressure, or by indentation, or by dithermy itself. So you have 4 ways to control the bleeding in those cases. So with the dissection of the retina, you will get the mass that you think it's enough for the lab to find it. You should know that procedure is not difficult. The most difficult is for the pathology to find the cell and to be familiar with those cases. This is why you need to build a relationship with the pathologist for a long time, just to be adapted for your small biopsy. And this is their frequent complaint, is that they don't have enough cells just to reach the diagnosis. And you should know, even with those maneuver you do, with the vitrectomy, diagnostic, or a big mass, the chance of getting the diagnosis is only 70%. So that means 30% of the cases, you can get a false negative result from the pathology. So you should keep the risk of that in your mind, just to decide what is the best for the patient himself. So you grasp the retinal biopsy, which is a big one, and you try to remove it through the small trocar, which is in most of the time will not be enough to be removed. So this is why you have to remove the trocar itself at the same time you pull to increase the removal. You see, even in this video, we didn't succeed to remove the mass because it was attached and it was lost, because it doesn't fall down on the posterior ball. So you have to do indentation just to find it, grasp it by the other forceps. Then you should increase the size of the sclerotomy. In this case, I use 18 gauge needle because it's easy to be removed. And it's always better to use the foreign body forceps to grasp this one, because it's big enough to be removed. Then you can take it out, send it to the pathology, fill the eye with gas, suture the sclerotomy, and surgery is done. So this is my part, and thank you for the chance and for the listening. Thanks.
Thank you very much for illuminating us with your expertise. Thank you.
Thank you very much.
I'll now have the proud privilege of, in the list it's you, it's according to seniority. It's you. You want the Nadeem to? Nadeem, दाऊद साहब कह रहे हैं कि ओरिएंटे आपको पहले बुलाया जाए. As per desire of our very dear and respected Daud Khan Sahab, Professor Nadeem Hafiz Bhatt is Salim Sahab. नहीं नहीं आ जाए. Professor Nadeem Hafiz Bhatt is currently serving as the principal of Allama Iqbal Medical College, one of the most prestigious public sector medical colleges. He was past president of Ophthalmological Society of Pakistan Center and founder and Ruhe Rawan of Pakistan Glaucoma Association.
बिजलियां चमक रही हैं या की हो रहा है?
Before you speak, Salim Saab, आपने Nadeem Hafiz Bhatt साहब is here. अगर आप थोड़ी सी अपनी ब्रीफ सा रेज्यूमे सलीम साहब पढ़ना चाह रहे हैं आप.
सुनाना किसको है? जिनको सुनाना है उनको सबको पहले ही पता है.
ठीक है, फिर बहरहाल यू गो अहेड प्लीज विद योर टॉक.
ओके,
Few words. इजाजत दें.
ओके प्लीज सर.
Few words about our speaker. Those from Pakistan, everybody knows him. Internationally, he is around most of the meetings, so people know him. But anyway, still a few words. Professor Nadeem Hafiz Bhatt is currently working as professor, head of the eye department, principal, Allama Iqbal Medical College, and he is director, medical education, Allama Iqbal Medical College, Jinnah Hospital, Lahore. He's a brilliant person, was born in 1963, did his MBBS in 1987, FCPS from Pakistan, FRCS from Glasgow and London, 97, then fellowship in oculoplastic. And he has been in the habit of standing first all the times, even in Public Service Commission. He did very keen and is a continuous medical education. He has written a number of books in ophthalmology and is so hardworking that they forced him to become principal of Allama Iqbal Medical College, where he is still working. Good luck.
Thank you, sir. Good afternoon, ladies and gentlemen. It's a matter of great honor and privilege for me to be standing before you and presenting Professor Sayyid Ramzan Ali Sayyid Memorial Lecture, Award Lecture, which is some kind of dream of every ophthalmologist, that he is given the chance of presenting such a lecture of a person who is one of the most respectable for all of us, one of the most senior ophthalmologists who has laid foundations of ophthalmology in this country. So, first of all, this is the topic of my lecture, Nanotechnology, the Future of Glaucoma Management. And I'm going to present a few slides related to the great Professor Dr. Ramzan Ali Sayyid, whose memorial lecture I'm going to present. Professor Dr. Ramzan Ali Sayyid, 1901 to 1988, and this was the handsome gentleman of that time that we all know that he's Professor Ramzan Ali Sayyid. He was born in a modest family in a small village in the suburbs of Lahore in 1901. He joined the King Edward Medical College and graduated in 1926. Distinction in medical studies in the subject of honors in anatomy, honors in midwifery, honors in hygiene, and served undivided India and Punjab. And then he did his postgraduate training in the field of ophthalmology. He obtained DOMS from London in 1937. DLO, at that time, the ophthalmology and ENT were together. So he did both diplomas. Then he the only highest diploma degrees awarded by Royal College at that time. He was then awarded honorary FICS in 1951, Jose Rizal Medal, which is the highest award of Asia Pacific Academy of Ophthalmology, commemorative medal of honor by the American Biographical Institute. But the most important thing was that a medal was instituted in his name, and it was announced by the President of Pakistan of that time, General Ziaul Haq. So this is, the Professor Dr. Ramzan Ali Sayyid medal announced, a gold medal for the first position in DOMS. This is he himself announced, but later on a medal which is the highest medal for OSP, that has also been announced and is in his name. So then he remained in Pakistan and served the King Edward Medical College and Mayo Hospital, and till 1958 He then joined Fatma Jinnah Medical College as professor and served there till 1966. He did research on and did innovation in many things, and three of his major innovations were decrew-cystoanostomy, a partial sclerectomy with iodine cases, and removal of cataract in secondary glaucoma due to hypermature cataract. So these are the achievements of Ramzan Ali Sayyed, Professor of Ophthalmology, and his son Asghar Ali Sayyed is sitting right in the hall. And so he's carrying the legacy of his father and running the hospital in his name, Ramzan Ali Sayyed Memorial Hospital at Temple Road, Lahore. Now coming to this is the group photograph where I think he is the gentleman. क्यों सर मैं ठीक कह रहा हूँ ना? ये उन्हीं की तस्वीर है ना ये वाली. हाँ जी. So he is the gentleman with his colleagues from abroad in one of the get-togethers. Now this is a global village of ophthalmology, and as my introduction has been given, I have served in all these capacities and still serving as medical educationist and research collaborator and managing editor, national coordinator and member of executive committee of Asia Pacific Academy of Ophthalmology. So no financial interest in the products. Now coming to the nanotechnology. Nanotechnology is the branch of technology that deals with dimensions of less than 100 nanometers, especially the manipulation of individual atoms and molecules. Nanometer is 1/1000th of a micrometer, which is 1/1000th of a millimeter, which is 1/1000th of a meter. So you can imagine the size of nanoparticles or nanometer. When we talk about glaucoma, blindness due to glaucoma is irreversible, and socioeconomic consequences to the society are in the form of treatment costs and loss of productive hours. Glaucoma affects about 67 million people worldwide. The incidence of this disease is growing by approximately 10% yearly, and it is the second leading cause of blindness in the world and the leading cause of blindness in African population. Nanotechnology in glaucoma is being used for four major areas. One is the measurement of intraocular pressure, for medical management of glaucoma, for surgical management of glaucoma, and for neuroprotection, regeneration and replacement. For the measurement of IOP, there are nano IOP measuring devices. These devices are mainly invasive, have maximum accuracy in terms of monitoring capabilities. These devices use nano or micro electromechanical systems, and a non-invasive IOP device design integrated a capacitive sensor and inductive coil made from 10 micrometer copper foil into a medical grade silicone contact lens. So the device is fixed in the contact lens, and that contact lens is placed on the surface of the cornea, and this keeps on measuring the intraocular pressure, and the sensor keeps on giving the signals and receiving the signals, and the IOP is recorded through that contact lens. Nanotechnology for medical management of glaucoma. The most common form of anti-glaucoma treatment is the administration of IOP lowering agents in the form of eye drops. We all know that beta blockers, alpha agonists and carbonic anhydrase inhibitors suppress the production of aqueous humor, whereas cholinergic epinephrine or prostaglandin analog-like compounds enhance the outflow. The conventional delivery system is inefficient and characterized by inconsistent outcomes for each patient. And the nanotechnology based approaches can be applied to develop the next generation of medicine called nanomedicines that provide targeted delivery, sustained release, bioavailability, dose accuracy, minimal tissue irritation, longer shelf life, and better solubility. So these are the all 7 advantages of nanotechnology which if we used in the delivery of the eye drops, that will be more useful. And these are the various nano delivery systems, and these are the nanocrystals, cyclodextrins, nanoemulsions, and nano diamonds, nanoparticles, and liposomes. So these 6 are the delivery systems through which the drug can be delivered in a very small particle manner and for a longer period of time. The selection of an appropriate system depends on the drug type, hydrophobicity, size, stability, target tissue, and route of administration. However, to provide efficient treatment, both systems, conventional and nano systems, should fulfill common characteristics such as biocompatibility, biodegradability, stability, and nanotoxicity. Current anti-glaucoma medications, which have been extensively studied in nanomedicine formulations, are timolol and cartiolol, pilocarpine, brimonidine, brinzolamide, and latanoprost. These are the three medicines which are being used very commonly all over the world for the control of intraocular pressure. So if we develop these nanomedicines for all parts of the world, it will be a great benefit to the patients. Contact lens designs for glaucoma treatment. Basically, the contact lenses are loaded with the drug, and these drugs keep on releasing slowly and gradually. So they are drug loaded. They're loaded with nanoparticles carrying drug and triggered drug release with the increase in temperature or presence of certain enzyme which is released. So the contact lens is loaded with nanoparticles, and the nanoparticles are carrying the drugs. So they are released slowly and gradually. So the patient doesn't have to use the drops normally, and the drugs are released gradually. Nanotechnology in the surgical management of glaucoma. Glaucoma drainage devices are frequently used in cases where IOP lowering medications and trabeculectomy are not efficient, and the models designed by Beovelt, Ahmed, and Kruppen are currently the main drainage devices available. Overall success rate in controlling IOP is 70% for the first year, which is reduced to 40% after 5 years. And preservation of vision are not significantly different. There are no significant differences in the overall incidence of postoperative complications. So conventional glaucoma implants would not give you that much benefit because there is a tendency of closure of these valves. So although the injection of antimetabolites such as 5-FU and metomycin is done intraoperatively, but the effect does not last very long, and injection to the blood still creates discomfort and risk of infection. So potentially the nano devices have been developed in which these drugs are loaded with the devices. So, and these drugs are gradually and slowly released, and up to the 5-fluorosil was shown to be released with a delay of 3 to 5 days, and continued until 28th day, and MMC was stable, and it was also releasing very slowly. So this is the time where the maximum, which is the time of bleb closure by fibrosis, and once this is loaded on the implant, it is going to release for this much period of time and will not let the bleb close. This is the device you can see. This is a nano device implant, and it is loaded with the nano drug 5-FU, and similarly AGV, and this is also loaded with the nano particles and nano drugs, and these are the plug filters. Artificial nano drainage implant, which is also called as ANDI, is composed of porous membrane and a polymeric shaft. The nanofiltration membrane was able to provide designed flow resistance. The cross-linking and clogging of protein inside the pores resulted in increased resistance over time. Finally, the nanotechnology in the neuroprotection, regeneration, and replacement. As we all know that glaucoma is also considered as a neurodegenerative disease due to the death of retinal ganglion cells, and retinal ganglion cell pathology can be attributed to various factors like chronic intermittent ischemia, defective axon transport, trophic factor withdrawal, and loss of electricity activity. Gene therapy involving delivery of protective or anti-apoptotic agents for regeneration and small interference RNase molecules for silencing inhibitory factors, and in a recent study, axon regeneration was achieved with the silencing RNA protein system. RGC, retinal ganglion cell replacement therapy, is also being devised with the help of nanoparticles. Both RGC and amacrine cells were not only able to survive in the scaffold, but also exhibited neuroid growth up to 500 micron in length. So regeneration replacement of trabecular meshwork is also possible with the help of nanotechnology. A plaque-like material deposition in the extracellular matrix, herniation in the extracellular matrix, changes in the expression levels, and modified action of calcium. These are the things which cause the blockade of the trabecular meshwork. And with the help of nanotechnology, you can replace the total trabecular meshwork, and the new trabecular meshwork will work as a normal trabecular meshwork and will not clog and will not stop the flow of aqueous humor from the inside of the eyeball. There is another aspect of nanotechnology which is the nanotoxicity. Just like all the drugs have side effects, this is also nanotoxicity. The main concern is the possibility of particle, excipient, contaminant, and inflammatory toxicity. And this enables nanoparticles to be involved in specific interaction with biological membranes, proteins, and other body fluid compounds and alter their properties. So I conclude that with the help of nanotechnology in future, IOP monitoring will be effective and precise, compliance of medical treatment will improve, complications of surgical treatment will be minimized, regenerative therapy of RGC and treatment will reduce the incidence of blindness, and glaucoma will shift from irreversible blindness to preventable blindness. Thank you very much for your presence and attention.
Bismillah ar-Rahman ar-Rahim. Now I have the proud privilege of inviting one of the most illustrious sons of the soil. Professor Muhammad Daud Khan Sahab. Professor Muhammad Daud Khan Sahab, could you please grace the stage for us? Professor Daud Khan Sahab graduated from Khyber Medical College in the year 1969, and he's been so profusely awarded that I'm just going to read the list of awards from his CV. Right from his formative initial career start, he was awarded the President of Pakistan Award for Outstanding Position in MBBS in 1969, Apao Prevention of Blindness Award 1987, Ramzan Ali Sayyid Gold Medal 1992, Apao Susruta Oration Award 1999, President of Pakistan Pride of Performance Award in the year 2000, Saudi Ophthalmology Society Award year 2000, Taiwan Ophthalmological Society Award year 2000, OSP Silver Jubilee Gold Medal Award for Distinguished Services in 2004, Dr. A.K. Das Endowment Award India 2004, the Apao Rose Jose Rizal Gold Medal 2007, the SARC Ophthalmology Lifetime Achievement Award 2008, the Pakistan Institute of Community Ophthalmology Lifetime Achievement Award year 2008, and I think he also prides himself on this award of Sir Stewart Duke Elder Lecture Award 2010. Must have been a lot of intellectual rigor to be awarded that Duke Elder Lecture Award. ICO International Duke Elder Medal in 2010, the American Academy of Ophthalmology International Prevention of Blindness Award 2013, the OSP Lahore Excellence Award 2014, the Guru Pranam Award India 2015, conferment of title of Professor Emeritus of Khyber Medical University, of which he was the founder, Vice Chancellor, Statesmanship Award from the International Joint Commission of Ophthalmic Allied Health 2016, the OSP Hyderabad Living Legend Award 2019, the OSP KPK Lifetime Achievement Award 2020, conferment of title of Member Emeritus Group International Council of Ophthalmology, and the list is, I think, with his whole life in front of us, he's a giant among the giants. Sir, I request you to deliver the talk on Raja Mumtaz Award lecture. Sir.
Bismillahir Rahmanir Rahim. May I say a very warm welcome to our very distinguished guests from Afro-Asian Council of Ophthalmology, and also distinguished ophthalmologists from all provinces of Pakistan. Allow me to present to you the Raja Mumtaz Quli Khan Memorial Lecture. Professor Emeritus Raja Mumtaz Quli Khan, the Dean of Pakistan Ophthalmology. A tall, very handsome and very well-mannered individual. He was always very well dressed and always carried a beautiful smile on his face. Professor Raja Mumtaz was an excellent ophthalmic physician, surgeon, teacher, and administrator. He was one of the 7 shining stars of ophthalmology who gave us such a strong foundation of ophthalmology in Pakistan. He was a symbol of altruism, honesty, integrity, kindness, compassion, and respect for others. He was very responsive to the needs of the patients, students, and the society. He would always emphasize on 2 things. We must always show a very strong commitment to continuing professional development. And we must realize that we, the medical doctors, are accountable to patient, society, and the profession. Professor Raja Mumtaz had a very strong commitment to promote the art and science of ophthalmology and ensure easy access to quality eye care services across the country on the basis of equity and justice. He would always emphasize on students to demonstrate interpersonal respect, compassion, and integrity. He was one of the strongest advocates of establishing excellent centers across the country for eye care human resource development, and eye care research and development. He played a key role in establishing some of the finest eye institutes at Lahore, Karachi, and Islamabad. Apart from his very kind, caring, and compassionate attitude, I always find him a very generous person. Whenever we needed money for any OSP welfare project, he would be the first to contribute. Ladies and gentlemen, please join me in an earnest prayer for the most noble departed soul. May Almighty bless him with his very special blessings. The topic is, how did OSP converted the dream of Professor Raja Mumtaz, comprehensive care for all across the country and beyond, into a reality? This is where we were in 1947. India was divided into 2 countries. It was a very joyful day for all of us, but it was a mixture of joys and sorrows. Indo-Pakistan wins freedom, but the partition caused death, disease, and destruction and displacement of some 20 million people. What were the challenges that we were facing at that time? And some of them we are still facing. Rising population, aging population, poverty, illiteracy, inequitable distribution of resources, extremism, political instability, and regional conflicts. Let's look at the challenge of rising population. 1951, East and West Pakistan, total population was 34 million. 4 million, 34. Where are we today? Just Pakistan is 223 million. Bangladesh is another 180 million. So you can see the change, the sea change. How about aging? In 1950, our average age was 44 years. Now our average age is 68 for male and 69 for female. Where were we in terms of eye care services? few missionary hospitals. Sir Henry Holland and his sons in Quat and Shikarpur, and Nawal Christine Taxla. Mew Hospital, Civil Hospital, Karachi, and few family-owned cottage hospital in Punjab. Pakistan inherited only 78 registered doctors and only 7 eye specialists, out of which 3 were from United Kingdom. Eye care services in 1950 and 60. New eye departments came in public sector in Karachi, Multan, Peshawar, and armed forces created few departments. However, no organized services were available for 80% population. The birth of OSP. How did OSP come into being? John Holmes wrote a letter to Professor Raja Mumtaz in July 10, 1957, inviting Pakistan to join Asia Pacific Academy of Ophthalmology. Lieutenant General, OSP was created, Lieutenant General W.A. Burke became the president, and Professor Raja Mumtaz became the Secretary General. W.A. Burke in 1962 became Vice President of Pakistan, and he invested in 3 key institutions of health, which in fact changed the fate of Pakistan. CPSP, College of Physicians and Surgeons of Pakistan, JPMC, Pakistan Medical and Research Council, and Pakistan Medical and Dental Council. We had a power meeting in 1979 in Pakistan, and the President of Pakistan came to attend this meeting. World Health Organization was watching this drama, and immediately after that meeting, they invited a gentleman from Australia, and Professor Hugh Taylor, a very renowned professor working in the United States. He was asked to look into the eye care status of Pakistan. And the nutshell of his report was the prevalence of blindness in the country was more than 2%. There were only 80 ophthalmologists for 100 million population. There was gross mismatch between the population and the doctors serving them. Cataract was the major cause. Out of 64 districts, 45 had no ophthalmologist. And this was a wake-up call for Pakistan. The seed for Pakistan National Eye Care Program was sown. The President constituted a National Eye Camp Planning Committee in 1985. The first national and 4 provincial coordinators were appointed in the same year. The first population-based survey on blindness and visual acuity was conducted in 1987-90. Professor Saleh Mehman was appointed as the first chairman, a very honest, very dignified individual. And he conducted the first survey in 1987 and 1990. My God. This is not working again. You have it. Okay, let's start from here. So Professor Saleh Mehman was appointed as the first national coordinator. Two slides are missing. But छोड़ दें, forget it. So anyway, I was appointed as the national coordinator, and I came out with a new concept of National Comprehensive Eye Care Program, which will be relevant to the country needs. So we did some operational research and looked at the current causes of failure. The district model, we proposed that we will have to do district development, district-based development, so that we ensure equity and justice. And we also wanted to know what was the future recipe for what would be the future recipe for success. The research result: district eye care service was dysfunctional because of the inadequate infrastructure, in a lack of appropriate human resource, lack of appropriate equipment, poor referral system, poor management, lack of networking and collaboration. The new district model was first tried in a mobile unit. We worked for two years there, and the site saver team came to see what has happened. And they found that each year we have done 1,000 surgeries in this bus. We then went to a district, and it ran for 2 years, and again the evaluators came, and again we had done what happened before we intervened into that district. There were 2 ophthalmologists, and the annual surgical output for cataract was 150. After intervention, there was only 1 ophthalmologist supported by technicians, and their output, his single output went from 150 to 1,050. So decision was made that we should now go to 10 districts. In 10 districts after that, an evaluation was done, and the decision was made that we should now go to 100 districts. So national task forces were appointed for refractive errors and low vision, childhood blindness, corneal blindness, trachoma, diabetic retinopathy, research and development, glaucoma, and human resource development. Conceptual framework for Pakistan National Eye Care Program was approved by the National Committee. It approved the concept of district comprehensive eye care program, set standards for physical infrastructure, set standards for technology, human resource management, partnership and collaboration, and we set goals for the first 5 years. The salient features of the program was developed as a package with infrastructure, HRD, human resource development and management. It will be comprehensive approach, promoting eye care, preventing eye diseases, curative intervention and rehabilitation. And it will be district-based, integrated, incremental, and comprehensive. And that would then join the national program. This is how the district and primary care was developed. And then it became the Center of Excellence, tertiary eye care, and then the districts. This was an institution which SSI and CBM, Site Saver International of UK and CBM of Germany, supported for training of community ophthalmologists, not only in Pakistan, but for, in fact, the entire Afro-Asian region. In human resource development, we had CPSP with us, Pakistan Institute of Community Ophthalmologists, and a similar institution in Punjab and Sindh came up. Pakistan became signatory for the New Vision 2020 Global Alliance in 2001. One of the features of this interaction was the partnership and collaboration between Government of Pakistan, World Health Organization, OSP, and international and non-government organization. Provincial cells were created in all provinces, and the management was done at 2 levels. One was the care, 7 centers of excellence came into being, 64 tertiary districts were there, tertiary centers were there, 120 districts were developed, and there was a very strong referral system between the primary and secondary services and tertiary services. And of course, on the other side, the management Ministry of Health was there, Department of Health was there, National Committee was there. 2 important national NGO came up with a series of hospitals created by LRBT across the country, and also one by the government at in Islamabad, the Al Shafa Trust Hospital. These were major two tertiary hospitals. So the sequence of development were first national survey, first 5-year plan, second 5-year plan, and second national survey. What was the net result? The prevalence came down from 1.78 to 0.9%. What was the impact nationally? The centers of excellence from 0 in 1980 went up to 7. Tertiary eye care centers were 10 in 1980, now they were more than 60. Functional secondary eye care centers were only 8 in 1980, and now it was 118. PAC centers, primary eye care centers were 0 in 1980, now they were 118. Cataract surgery went from 50,000 per year to 720,000 per year. Impact International, the institution at Peshawar not only trained Pakistani doctors, they trained doctors from Afghanistan, Yemen, Iran, Bangladesh, Jordan, Syria, Lebanon, Palestine, Libya, Sri Lanka, Indonesia, China, Nigeria, Kuwait, Egypt, UAE, Iraq, and Saudi Arabia. Future Pride, the third 5-year program, came into being at a cost of $46 million, which the government of Pakistan paid. And we have a recent report from Professor Asad Aslam Khan, who is the current chief executive, and he has reported that they have further reduced the prevalence from 0.9% to 0.45%, which is a unique achievement. These are the leaders who inspired us. These are the people who supported us. These were the acknowledgements of international partners. These were the acknowledgements of the teachers who participated in teaching, training our individuals. This was the power of ownership and partnership, and acknowledgement of national partners. And thank you very much.
Could you come over on the stage, sir, for the award of the shield, sir? Let me invite Sami or Rabia Al-Rabia. Am I correct?
Rabia, right.
So he's going to speak on measuring and treating selective high-order visual aberration. Dr. Sami Al-Rabia was born in Kuwait 1952, did his MBBCH from the medical school in Cairo in 1977, did his FRC off in 1984, vitreoretinal subspecialty in 1984, cornea subspecialty in 1985, chairman of ophthalmology departments in Kuwait, started LASIK procedures in 1989, has done over more than 40,000, is that correct? Refractive procedures. Founder and co-chairman of PAC, Pan-Arab Council of Ophthalmology, with all the administrative responsibilities in arranging conferences in Egypt, Lebanon, Jordan, Morocco, Iraq, UAE, Syria, and Bahrain, and shared in many ophthalmology surgery camps for poor and blind people. Over to you, sir.
Thank you. Bismillah ar-Rahman ar-Rahim. Inshallah, first of all, I'm really glad to be here. Thank you very much for your invitation. And I hope this lecture is to the front, to the future. Selective measuring and correcting the high-order wavefront aberration. To pay less and gain more. Take it, this is the message. Pay less and gain more. Now, in cases like advanced keratoconus, post-PKP, corneal scarring, whatever, those cases who have irregular astigmatism, if you plan to try to correct them with ICL or with clear lens extraction, whatever, they never get good vision because they have irregular astigmatism. If you change this irregular astigmatism into regular astigmatism and then proceed with your own technique, there is a lot of difference in their life. And then, say in advanced keratoconus, poor vision with full correction, whatever you give him, he doesn't see very well. But if you just, with 30 or 40 micron, you remove some high errors of refraction, you can give him the glasses and he can get very good vision. Not to forget the post-LASIK complication, those with coma and those with spherical aberration. These patients, though they may say 20/20, but they are unhappy with their vision. And then we can do on normal cornea to induce abnormal cornea by intention. We just go for normal cornea, we change something in this normal cornea, make it abnormal cornea, and we will see why. Ocular wavefront is the difference between the axial or the ideal wavefront on ideal patient and the patient who you have it. The difference is the wavefront. And the wavefront is either low order or high order. Low order is corrected by glasses. The low order is the sphere and cylinder. Whatever sphere and cylinder, only you can correct it with glasses. Patient is happy. These are the low orders. But the high orders are not correctable with glasses. These are the patients we are going to discuss. Those patients who, whatever you give them their refraction, they never improve. Now, we should thank Zernike for his way of describing us for us. Now, what he did, he made a large pyramid of stones. And this pyramid starts from the zone up. Zone 0 and zone 1, really, for us, it has no importance. And these definitely for physicists has importance, but for us, no. Now we start from the second row. The second row, because 0, 1, this is second. Second row is what we call the low order aberration. And in this row, if you can look carefully, this is the astigmatism here and here, and here is the sphere. Sphere is either plus or minus. If this goes down, this is minus. If this goes up, plus. And this is the astigmatism, and this is also the astigmatism. What's the difference? I'll tell you soon. And then if we go further down, this is the third, and from the third downward, this is high order aberrations. These are not being corrected. And this is the coma, and this is the coma. But this is vertical, and this is horizontal. Now, look there again, we have the trefoil. And then if you go down, we start to see now the spherical aberration. And then we have the astigmatism, the secondary astigmatism, and then we have the start increasing. So the pyramid is increasing. If you look in the horizontal line, if you are in the second row, this means that there is two aberration. 1, 2, 1, 2, either down or up. If you go to the third line, you have 3 aberration. 1, 2, 3. 1, 2, 3. If you go down, there are 4 aberrations. 1, 2, 3, 4. 1, 2, 3, 4. So the way he arranged it, the more down you go, the more number of aberrations. Okay? And then, if we look, I hope here. Okay. Now here, the most important for us is the coma and the spherical aberration. And these are the one which we said induced by us when we treat the patient. Now, how to measure? Because the problem is how to measure, how to know that these are really high and you need to treat it. We have many machines. Either I use the OBD scan 3, or you can use the Galilei Schimflung. So exactly, if you have any Schimflung machine, it will measure these high order aberration. If you look carefully here, and this is an OBD, I just made it on 3 screens. So this is what you see, the croissant of keratoconus. But look carefully, if you look at the coma is high, 0.5 something. But the spherical aberration is not that much. The trefoil is not that much. So my problem is here. Again, this is another case, but now here, all are high. The trefoil is high, the spherical aberration is high, the coma is high. So you can select one by one and study one by one. And then, look at this. This is even worse. But this is what we call nipple keratoconus. And because of that, here, look at mainly the spherical aberration is so high here because of this position. Now, if you look, this is a very high astigmatism. Is that a bad cornea? No. Look at the coma. Look at the spherical aberration. And look at the trefoil. They are all good. Look at this shape. It is too bad. But look at the function is good. So I'm not worried about this patient. Now, and then if you go to the Galilei, this is not here. And then you ask your machine, please, my machine, show me the coma. Here, the coma, you can see the coma and you can read it. It is 1.2, so this is high. Or maybe the same machine, ask him, what about the trefoil? It will tell you it is high. So you can select. And then what about spherical aberration? It is not that much high. So there is no problem with spherical aberration. So you know now what to treat, which wavefront aberration to treat. Don't just go and push the machine. And this is again, if you look at the shape, if you took all the high orders from 5 down, they are nothing. If you add on top of them the trefoil, still not bad. If you add on them the coma, still not bad. If you add them all together with spherical aberration, not too bad. Spherical aberration, no, it's not too bad. Okay, so, and this is the total of everything, which is around 0.4, which is excellent. So this is the way you study it, one by one, to treat it. So this is how to measure it. Now, PTK, are you going to do, when you do customized PTK to select these cases, so you have to go for customization. Is your customization wavefront guided or topography guided? This is the question. Are we going to treat the function or the morphology? If you are going to treat the function, it is normal topography, so it is wavefront. If you are going to treat the morphology, so it's abnormal topography, so it is topography guided. Is there any difference? Yes. The wavefront guided is through the pupil. This is very important. It is not on the visual axis. It is on the center of the pupil. So if your pupil is shift, or you have big angle kappa, or your treatment will not be on the visual axis, will be away from the visual axis. And it is tissue saver. Because why we prefer wavefront? Because wavefront may see an abnormality on the corneal surface, but this abnormality is being corrected by another abnormality at the back surface. So the wavefront, when he looks at it, he looks at it as normal because they compensate each other. So it doesn't treat it. While if you look at the corneal topography, he looks only to the anterior and he sees, wow, this is big one, let us correct it. And he corrected, and then we are faced with the other one down, which was compensated. So the wavefront is really a much better result because it goes for the function and it doesn't save too much tissue. But we have to solve the problem of this of the centration. Now, spherical aberration, I call it pure. Spherical aberration, pure. What does that mean? That is normal topography. So here, normal topography, I have to go functional. But something like coma, this is abnormal topography. I may join both of them, the wavefront or topography guided, because they are mixed here and helping. Now, if I'm going to do just the pure one, so here, epithelial shape does not matter because I'm looking for the function. And epithelial map, epithelial thickness doesn't matter because I'm not, it doesn't really it's the shape. And even if this patient had underwent LASIK before, I can lift the flap and do it on the bed. So this is spherical. It has nothing to do with the epithelium. It's simple. But the coma aberration, like the ectasia with the center treatment, now both of them work together. And then converting irregular astigmatism to regular astigmatism comes also in the group of together. Spherical aberration, mostly post-myopic correction, as we said, and the other thing which I just mentioned, that we do it to normal person. We intend to reduce the positive spherical aberration for presbyopia management. So if you have a patient, you want him to read better, you can go only to induce some spherical aberration, so you will improve his reading facilities. Now, what is the spherical, may ask me, what's the spherical aberration? This is a normal sphere, and the light here is not like, the light in the center is not like the light in the periphery. That one in the center goes to the retina directly, but the more the light goes away from the center, it is more convex, and the treatment will be in a line from here to there, not on a spot. This is if the cornea is rounded, is spherical. But our cornea is not spherical. Our cornea is from the very beginning, it becomes flatter and flatter and flatter, and this is so to push the light from here down. So all the light goes down to one spot. And alhamdulillah, God makes this cornea this way. And after treatment, if this is normal and you do, you can see this is myopic correction, you can see there is increase in the periphery. You see the steepness in the periphery? And if you do hyperopic, there is flattening on the periphery. So you are changing the periphery by your treatment, and changing the periphery will induce some positive aberration, either up or down. This is to explain the whole story. So this is if the cornea is, if it is sphere, it's come here, but this is the normal. It is slightly flattened, so it comes here. You may ask me why it's not here if it's normal cornea, because the lens is there adding to the power of the cornea and bring it to zero. Now, once you do myopic correction, so it comes even further forward, and the lens will bring it, so total will be here. This is called positive because it goes up, positive aberration. And if you do hyperopic treatment, it is flatter there, so instead of here, it goes down, so it is less positive, and if you add the lens to it, it will be down here, it will be negative spherical aberration. Now look carefully here. If you do topography guided and wavefront guided, topography guided does not change the spherical, 0.3, 0.5, even made it worse. And in this case, you can see I'm only treating the spherical. But when we do the wavefront guided, it's almost to 0.3, almost to the zero line. Patient will have sharp vision. So here, if it is pure, go for wavefront. Now, look again. This is topography guided, this is wavefront, and you can see the difference. The shape is much better with topography guided, with topography guided, but function is much better with wavefront guided. Now, again, shape is not been changed, but the function is better. Shape is excellent, but no change in the function. Now, what do I mean by inducing irregularity? We may intend to increase the negative spherical aberration. We said every patient, every one of us has positive spherical aberration. And if we do something that we can push it down to the zero, so either we say increase the negative or reduce the positive, it is the same. Because this is the retina and this is the positive. If I reduce the positive, means I'm going to the negative side. So it's increase negative spherical aberration will increase by increasing the Q value in the non-dominant eye of the patient, and this will help the patient to have better reading. Now, look at this one. This is a patient with hyperopic correction. We can see here that he had hyperopic correction. Also, he had some astigmatism corrected, and that's it. But now, if we look at his spherical aberration was 0.24, becoming 0.81. It's not that much. It's only 0.81, not really improved. But I did not really touch the spherical aberration on my machine. Now, once I correct this on my machine, I said, please correct the spherical aberration. It became to 2.45. So it is, imagine, from 0.24 to 2.4. So this means that I really improved the vision of the patient for near, and by only 10 microns, pay less. 10 microns, you get better quality. Again, this is the patient with post-treatment, and he's not happy. Now, if we do him, no treatment there. Once you do excess treatment, look, if you look carefully, it was 8, and then it became 13. So it's only 5 micron difference. With this 5 micron difference, I changed look at the spherical aberration, it was 0.7 and 1, so very high. I reduce it to 0.2. So reducing the positive aberration gives the patient a much better vision. Now this patient it is shifted up, so he has coma definitely, and also he has spherical aberration, because you can see how rounded it is. This is before I treat, nothing is there, and nothing is there. But if you can see, I just selected coma as well as spherical aberration, few. And look at the difference in shape. And look here, 0.77 becoming, how much is it? I can see it. So we are reducing sphericity, and 0.78 coming to 0.6. So we are reducing it to improving the position only by 19 microns. I did nothing here except 19 microns. So I paid 19 microns of the patient cornea, and I gave him, he got less of his coma, he got less of his spherical aberration. Now, one of our friends, he asked me, how do you do that if you are having a patient? Suppose this is the patient, I'm going to do one eye for distance and one eye for near, and if you look carefully, he was 44 before surgery. And then look at this eye is 40. So there is 4 diopters correction. So this patient had correction of -4 in this eye. Now, the same eye, it is the right. If I am going to do this one for near, look at it, 42, means that I left by intention 2 diopters for near. Okay, so first of all, I left him myope. If you compare it, so if I correct him fully, it will be 40. If I'm going to leave some, it will be 42. But this is not the story only. Now, look carefully to the periphery here. Periphery here and periphery there. Look, it has become -1 and -0.8, while here it was very low number. This one is exactly very close to previous surgery. So if I do big treatment, full correction to the dominant eye, I intend not to change the Q value. But for non-dominant eye, I do smaller treatment with higher spherical aberration, intended to leave some diopters, and intended to increase the negativity or reduce the positivity, and this patient will have a very good depth of focus for this eye.
Dr. Sami, we are running out of time.
Okay, decenter ablation, again, this is it, you can do both, and then good shape, bad shape, they are both the same. Just the technique, this is you are doing nothing, and then only trefoil. Look at it, it's only minimal improvement. But if you add coma, from 2 it become 0.7, so now you are treating trefoil and coma. So trefoil and coma. You tell me, what about the total? Look at this patient, 10 becoming 6. So this means that he had low error. But I did not correct the low error. I sacrificed he can have glasses. But now with the glasses, he can have better vision. Before, he could not have glasses with vision. And I hope this is again the same. And this is the nipple one. This is the mainly spherical aberration, what goes. And then, look here, I corrected the spherical aberration from 7, and then induce it to, see astigmatism from 7 to 0.14. So disappeared completely. I first do this treatment here, and then I did some spherical aberration. And thank you very much, and sorry for keeping you all this time.
Thank you, Dr. Sami. We now call upon Mr. Muhammad Al-Amri. I request Professor Lateef Chaudhry Sahab, Patton OSP Center, to kindly come over to the stage to hand over the shield to Dr. Sami Al-Rabia. Right now. Is Dr. Muhammad Al-Amri here? Yes. Right. So you're going to talk about real life experiences with Illuvian in the management of diabetic macular edema. And Dr. Muhammad Al-Amri is honoring us from United Arab Emirates. Could you please have a brief introduction? I could read it from your slide. You're a consultant ophthalmologist at Al-Qasimi Hospital, Sharjah, UAE. You have a special interest in anterior segment surgery and medical retina, and you are an adjunct professor in medical college at Sharjah University, 2011-2018, and you're the founder and president of Middle East Ophthalmology Meeting. You're a founder, vice president, and head of scientific and organizing committee of OIC, founder and first president of Gulf Retina Group, GRG, and member of UAE Right for Sight Committee. Dr. Muhammad Al-Amri, please.
Thank you very much. Assalamu alaikum and Bismillahir Rahmanir Rahim. Just I will give you a talk about real life experience with the Illuvian, which is a fluocinolone acetinoid intravitreal injection. First of all, we will give a little bit about hint about diabetes mellitus, and the incidence of diabetes in the UAE is very high, and we are ranked as in the 15th country in the worldwide with the prevalence of diabetes. As you know, the prevalence of diabetes for all age groups worldwide was estimated to be 2.8 in 2000 and will be increased up to 4.4 in 2030. And now even they are having another estimations, it will be more and more. The prevalence of diabetes in UAE is now, this number it was before. The new statistic that we get is now is 16.2 rather than 19.2. Here you can see the prevalence of worldwide and Middle East, and you will find that most of our countries, especially Saudi Arabia, Kuwait, Qatar, and UAE, Bahrain, we are within the 10th high number or percentage of diabetes mellitus in this in the worldwide. And now United Arab Emirates is number 15, and you can see here the prevalence also it's 16.3 or 2. Diabetic retinopathy in USA, the prevalence of diabetic retinopathy is 17% in a person with diabetes for less than 5 years. So who's having a diabetes less than 5 years, there will be the percentage about diabetic retinopathy will have the chance about 17%. But you will see that these patients, when they are going to be more than 15 years, the privilege, the percentage or the percentage, it will increase very dramatically to be about 98%. Proliferative diabetic retinopathy is varied. There is a different estimations. It is 1.2 in person with diabetes for less than 10 years. And also, it will be very high when it becomes a patient with proliferative diabetic retinopathy more than 35 years or more. It will be increased to almost 70%. Diabetic macular edema, which is the most important disease and causing vision loss in a patient with diabetes. And that's why we are talking about the different type of management of diabetes. All the patients with diabetes are at risk of developing DME. So most of them, they are having the risk. In US, the prevalence of macular edema is 29 in a people with diabetes for more than 20 years or more. DME also estimated of the DME prevalence rate range from around 1% to 12% of all people with diabetes. There is a study, it was done in English and British, and they found that 7% of people with diabetes have DME, and of those 7%, there will be a 39% they are having a central cystoid macular edema with visual impairment. So visual impairment, it will be around 40% of those 7% they are having diabetic macular edema. I'm going now to show my experience with using the Illuvian, which is a fluocinolone acetinoid, about 0.19 micrometers. That is intravitreal injection. The number of cases, actually, I select all those they are not used as a first case choice, but I choose this one, those only 21 case. I have almost or more above 50 case that I give Illuvian, but I include only those they are have a pre injection like Lucentis or anti-VEGF or steroid. So the 21 case, each of them is a unique, common to them that all had received Illuvian implant, post anti-VEGF and steroid challenge test with a good response. Post Illuvian, few eyes had received additional anti-VEGF as a top-up treatment. Patient had need follow-up months, either 1 and 3 and 6, 9, then 1 year, 1.5 year, or 18 months, 24 months, and 36 months. For the Illuvian, it's work for 36 months. When we are measuring the average of these 20 patients, the retinal thickness was average of around 447, and the decrease after, or there will be a response peak of this reduction, it is in around 35% at mostly at 18 months. and maintain a reduction up to 36 months. But to be honest, it's most of the time we are facing that they are starting having more or increasing again in the central retinal thickness after the 30 months on all of the, most of the patients. Most of them, they are having, we can go for a second implant even before continue or finishing at 36 months. Regarding the visual acuity, there was most of the time this kind of, the Illuvian, it give a slow release, and so there will be a maintenance actually of visual acuity, also on dropping or decreasing or reduction the central retinal thickness. And you can see here also the visual acuity, it is average 0.5, and it will at the baseline. And then according to the follow-up, you will see there will be a little improvement, especially in the first month. Then you will find that it become decrease on 18 months. This one is because most of the time they will have a cataract. That's what it affects that, or there will be a little bit drops in the visual acuity at 18 months after the injection. So implant maintained or improved visual acuity after switching from anti-VEGF and dexamethasone with huge reduction in the following need of injection. Most of the time we give 1 injection or 2 injection of anti-VEGF, or sometimes 1 dexamethasone injections. Regarding the intraocular pressure, it is also one of the concerns that we are all the time talking about when we are dealing with steroid, but actually it is not that much. It's all the patients pass through IOP challenge test before receiving implant according to the label, and they didn't show elevation intraocular compared to the baseline. The patient has experienced increased intraocular pressure by the second year and respond well to the use anti-glaucoma medications. So most of the patients, we didn't have any patient that need any surgical intervention as glaucoma. We are having only less even than 20% of the patient, they need 1 medications, and few of them, maybe around 7 or 8%, they may need more than 2 drops anti-glaucoma. Regarding the top-up is matching with the study that they mentioned, and you can see here that 70% of the patients didn't require any top-up, so only about 30% they need required 1 top-up, sometimes either anti-VEGF and some receive dexamethasone. Just I select few cases to share with you about these cases. The first case is a patient, is a 70-year-old male patient. He is a diabetic for 14 years, anterior segment with a normal level, and both eye shows diabetic macular edema. Right eye was treated with 4 Lucentis, 2018, and 2 Ozurdex 2019, then Illuvian injection. You can see here, this is the diagram. It shows that pre-injection, the patient in 1 year, he received 4 anti-VEGF and 2 short-acting steroid, and still not that much responding. Then I switch, and actually we are switching in that time because these patients, most of them, they are included and given Illuvian in the era of COVID, and that was very reasonable because it was very difficult to bring the patient and to have more injection and more restriction happen during that period. So during the 3 years treatment with Illuvian for this patient, he received 1 Ozurdex at the top-up at month of 28. What is the decision to give anti-VEGF or dexamethasone Ozurdex? It's according, there is no study or something to show or rule that to tell us what kind of treatment we have to give or the top-up. But it's a figure out. I found those patients, they are having anti-VEGF, a very limited or less increase of retinal thickness or change in the visual acuity, not that much from the baseline, then I give only anti-VEGF. But when I feel that there is a high elevation of the central retinal thickness above 400 or 500 and the vision is changed, at that time I decide to give more Ozurdex rather than to give anti-VEGF. This is the photo or OCT with the photos and also the map of the macula pre-Illuvian, and you can see here is the first one is pre-Illuvian injection. Then after 2 weeks post-Illuvian injection, Not all the cases actually we are bringing after 1 month, but some cases we are, especially in the first of the beginning of using the Illuvian, we try just to have an idea about how the effect is going as early as possible, and also to monitor if there is any change in the intraocular pressure at the beginning, but after that we are get used and we have experience, then we are bringing them in a 1 month rather than 2 weeks. Then 1 month post-Illuvian, you can see there is a drop and in the central retinal thickness. 3 months post-Illuvian, also the patient, also there is an improve in the visual acuity, but I didn't bring here the visual acuity. 6 months, you can see, then 15 months, then 28 months post-Illuvian injection. It's very clear that there was a reduction and maintaining of the central retinal thickness of this patient. The other case is a 65-year-old female. She is a diabetic, 15 years old, and first time we saw her, she was on 2019. Visual acuity 0.7, anterior segment with a normal limit, and intraocular pressure also normal. Posterior segment, both eyes, proliferative diabetic retinopathy and DME. Left eye was treated 6 anti-VEGF Lucentis in year 1, then switched to Illuvian. This is how the patient's pre-injection, you can see of the diagram. So 1 year, the patient received 6 anti-VEGF, but still there is no good response. So I tried to give him here I didn't give actually a dexamethasone, because not all the patient I give them a test of dexamethasone. Sometimes I give only drops. As according to the approval of this medication, there is 2 approvals. In United States, they are asking for dexamethasone before you are giving Illuvian, but in Europe, there is no need to give actually a dexamethasone as a test before giving the Illuvian. And this is how it was pre-Illuvian injection, and this is also the first one is pre-Illuvian. Then 3 weeks after that, you can see 9 months, 12 months, 13 months. You can still, there is not that much response in comparison, but there is a slow response, actually no response at all, but not as anticipated or was seen in the first case. I would like just to show how the response in different patients, not all of them are good as it should be. This is 17 months, still 18 months. You can see there is still now 19 months here. We have post-Illuvian injection. You can see now more better. Now 20 months post-Illuvian, then it is more and more. 21 months, and that was the last time we saw the patient. He didn't come. He came, but it's still now 21 months after the Illuvian injection. This is the last case I will show with you. I will share with you. This 70-year-old female, also 25-year diabetic. She's hypertensive and hyperlipidemia. Patient right-wise treated from 2015 to 20 with multiple anti-VEGF and Ozurdex. So around 5 years she was taking anti-VEGF and also Ozurdex. 1 year before the Illuvian injection, patient received 2 anti-VEGF injection and 1 short-acting steroid. This is how the patient pre-Illuvian injection. So in the 1 year before, she received only 2 injection anti-VEGF and 1 short-acting steroid. In 2 years after the Illuvian treated patient received 2 anti-VEGF here. So the top up here we give 2 anti-VEGF. This is the pre-Illuvian injections, and you can see it here. It's only 1 slide here. I didn't show more. So, and this is 2 weeks, and then you can see the response in 28 weeks. I will not go. I will go very.
Dr.
sharp,
Mohammed,
fast. Yeah.
can I remind you about the time, please?
Okay, how many minutes I have, please?
You had 15 minutes, so you are almost there at 15 minutes. But
Okay, I will just go to conclusion. So there is many study actually, different study, IRS study or others, and they are just matching what we are doing. And this Baladan, so this is only the last one. Maybe I will go about this one, the Baladan study. This post hoc analysis correlate between previous number of anti-VEGF injection and visual outcome after switching to Illuvian. And the main message from this one, as early as we switch, before we are having chronic ischemic changes in the macular edema, the most result we are giving in improvement in the visual acuity. And thank you very much.
Thank you very much for your illuminating talk. Can I invite again Professor Latif Chaudhry Saab, and to grace the occasion for us, each speaker feels honored on behalf of the OSP Pakistan that if you personally come over. Yes, we can do it here. Can I invite please Dr. Muhammad Al-Amri to come in front of the stage, please? The last speaker of the session, Professor Aman Madanath. He is a retired general from the Royal Medical Service of Jordan, head of the Department of King Hussein Medical Center, board member of European Society, examiner at the Royal College of Physicians and Surgeons of Glasgow, co-founder member of Afro-Asian Retina Society, and he has to his credit many published papers and participated in multiple international conferences. Over to you, sir.
Thank you very much, sir. I'm really honored and thrilled to be part of this session in the memory of very esteemed late ophthalmologists. So thank you very much. And I also extend my thanks to the organizing committee and Dr. Professor Hussein Khagan for the nice invitation. My talk tonight, this evening, will be about vitrectomy for the advanced diabetic eye disease. Diabetes mellitus, in fact, is 2 to 3 folds more prevalent in our region in comparison to the Western countries. Large number of eyes, however, progress towards proliferative stage requiring surgery because of we don't have a proper screening program in the country, and people, they tend to present late. There have been vast improvement in both surgical technique and instruments, resulting in better visual outcome, beside the use of anti-VEGF preoperatively. We are going to discuss tonight a group of 6 patients who lost one eye. They are one-eye patients and have an advanced proliferative disease in the other eye due to complications of diabetes mellitus. The pre-op visual potential was examined by checking the visual acuity. The duration of visual loss, that was very important, because the longer the duration of vision loss, the poorer the prognosis. And a B-mode ultrasound was done just to see the traction and to see the extent of the traction over the retina. Also, OCT and OCTA was done to see the extent of retinal membrane and presence of diabetic macular edema, and if there's any foveal involvement in the traction, any loss of foveal depression, the presence of diffuse macular thickening, diffuse retinal thickening, the integrity of external limiting membrane and inner and outer segments of photoreceptors, and the presence of ischemia in the macular area. All these are important points regarding the prognosis. For example, this patient, if you look at the OCT, you find that his macula looks fine. But when you do the OCTA, you find a lot of ischemia in this macula, so the prognosis might be guarded. Surgical technique, remove the anteroposterior traction, creating posterior hyaloidotomy, clear the subhyaloid hemorrhage, Vitreolysis and the concept of double layer to get into the right cleavage or dissection plane. This is very important. Relieve tangential traction, segmentation, delamination, and block dissection or combination of all of these. Hemostasis is very important. Do I peel the ILM? I don't peel the ILM in most of these cases, except in a very rare situation where there's corrugation or traction, significant traction on the macula. The surgical technique, do we need to remove the lens? Even if the cataract is minimal, I do remove the lens in most of the cases because I need to shave the vitreous up to the aura. So I do, and in all these cases, usually there is a good element of cataract. The vitreous-based shaving and around the plugs, as then if you don't do this, neovascularization and the patient will rebleed later. I'll discuss the role of the cutter and the bimanual technique. This is the first case of 59-year-old male patient, type 2 diabetes for 18 years, hypertension, impaired renal function. He's still young, but he's blind, no perception of light in the right eye, and the left eye is counting fingers, 50 centimeters. This is Can we run the video, please? I think, wait. No? Wait, here's the video. This is the case I'm going to show you briefly. There's a lot, this is in the middle of the case, a lot of epiretinal membranes, traction, and we use, this is 23 gauge vitrectomy. And I use the cutter to remove as much as I can of the membrane. And you're not always successful in removing the membrane or the adhesions by using the cutter, so you need to use your scissors. Scissors are important in diabetic vitrectomies, and I use a horizontal, most of the time horizontal scissors. Sometimes I rarely use a vertical scissors to cut the membranes and to try to get into the proper cleavage plane. This is the horizontal scissor used to cut the adhesions, and then we use the cutter to remove the membrane. Even I can remove the most small adherent membranes to the retina using the cutter by facing the opening of the cutter upwards and engaging the tissue and then cutting, and that's it. Definitely we complete this by removal of the membrane over the optic disc. We don't cut over the optic disc. We don't use the cutter of the optic disc. We just peel, and we should be patient and slow in peeling the membranes over the optic disc for the fear of bleeding. And then we continue the case by using the cutter and removing the rest of the membrane. This is also, can we please run this video? Then after removing all this membrane, please can we run the video? Hello, can we run the video, please? After removal of all these membranes, in fact, it's very important to go ahead and shave the vitreous up to the aura in these cases. If you don't shave the vitreous up to the aura serrata or up to the periphery, then you would have neovascularization later on, even around the plugs, and the patient will rebleed, and he will continue to rebleed after surgery. So it's very important to do this, and it's very important to indent peripherally and do a proper laser treatment. Even I do it up to the aura serrata by indentation and lasering the peripheral retina. This is the case on the right-hand side before, and this is the case after surgery. The patient improved from counting figure 50 centimeters, 2.7, he's back to driving his car. This is the same case. This is a 55-old lady. She's a one-eye patient. She's an acting professor. Her right eye was lost in a car accident during childhood, so she's a one-eye patient. She's 0.4 vision, and she's complaining. She cannot see her students in the theater, and she has a problem, and she insisted to do the surgery. You can look and find there isn't an extensive membrane over the retina, as you see, but there is a sheet over the macular area, but there is a vascularized thick tissue over the optic disc, and this is critical in a one-eye patient. Can we run the video, please? Well, she was given Avastin 4 days before surgery, and you can see finding the right cleavage plane is very important in these cases to remove this tissue properly. And the tissue was very thick and was adherent. I could not peel it easily, so I used my horizontal scissors to remove this membrane. This is the real time. You have to be careful using the scissors near the optic disc because of the presence of the major vessels. If you injure a major vessel, you'll end up with a profuse bleeding, and you don't want this in a one-eye patient. So you have to be careful. You should know your plane of dissection. You should properly cut the tags of adhesions between the disc and the retina. And you do this slowly. You don't be hasty in peeling and removing the disc, the membranes from over the disc. As I told you, when you come over the disc, you cannot cut. You cannot use the cutter very near to the optic disc. So the best way is to peel, and to peel very slowly and to peel gently until you remove most of the tissue or all of the tissue. Most of the time, if you are patient, if you are meticulous, you are going to remove most of it. It's not harmful to leave part of it over the disc if you cannot remove all of it. The challenging thing in this case is the bleeding. If you have a bleeding over the disc, you cannot cauterize freely in this case because you might all at the same time cauterize the nerve tissue at the disc. So you do, as I said, you do this gently, and if you need to do cauterization at the fibrovascular tissue, you get the power of your cautery to the minimum, and you use it to the minimal to remove this bleeding. Sometimes, if you just elevate the pressure inside the eye, you will be able to control the bleeding. If you have a small tag that's still bleeding, you can just gently cauterize it. This is the case before surgery. She was 0.4, and this is the case after surgery. She is back to 6.6. This is another challenging case, 71-year-old male patient, one-eye patient, type 2, 25 years, hypertensive, ischemic heart disease. Can we run the video? This is one of the most challenging cases. In fact, if you look, there's a tabletop fibrosis. If you look at the blood vessels, they are ghost vessels, and there is subretinal hemorrhage. This is, in fact, a very unfortunate, he was a very unfortunate patient, and I talked for a long period with this patient to tell him that the prognosis will not be good. Look at the vessels, they are all of it ghost vessels, and look how adherent is the tissue to the underlying retina. I started using one hand and scissors to try and remove the membrane, and it was very tedious, it was very difficult. I hate to create holes and tears in my patient. I tried to just keep the retina uninjured. So ultimately, I went and I fixed a chandelier, and I did a bimanual technique to try and remove this membrane of the macular area. You can see now that I'm using a forceps and the scissors and a bimanual technique to remove this tissue over the retina as much as I can. And in fact, when I removed the tissue over the macular area, there was a remnant of the tissue in the superior nasal quadrant. After I removed the tissue over the disc, I just stopped at this point because it was in vain to remove this part over the superior nasal and cause more harm to the retina. This is the case before surgery. He was counting finger closed, and this is the case after surgery. As you see, I left some fibrosis in the superior nasal side. It's not affecting his vision, and his vision is 0.1. Bimanual surgery, as I said, can we run the video, please? Bimanual surgery in these cases is mandatory sometimes. You start by one hand, and then during the case you find yourself obliged to go to bimanual technique because you don't want to injure your retina, you don't want to do more harm to your patient, especially in these cases. As I said, they are one eye patients, and they are depending on you. Some of them, they have navigating vision. Even if they have, the patient is having one counting finger 1 meter or half meter, this is a navigating vision for him. So there's a big risk of losing even this vision after surgery. So you have to be very careful and very meticulous. And I think bimanual technique in these cases, if needed, we should not hesitate to go ahead and do it. As you see, most of the membrane was removed over the posterior pool, and this was the last bit to be removed by manual technique, the forceps and the scissors, and then the tissue was removed using the cutter. This is the case before surgery. He was no perception of light in his left eye, was counting finger half meter in the right eye. This is the case before surgery, and this is the case after surgery. I put silicone oil in this patient. This patient has no injury, no holes, nothing. But this patient has a ceremony. His son wants to get married after 1 week. He told me, I want to see. And I was afraid that the patient might have a little bit of blood staining in his vitreous. So I put silicone and corrected. He was corrected to 0.4. And he came back after 2 months. I wanted to remove the silicone. He refused to go and undertake the surgery. He said, I don't want to remove the silicone. I'll be blind. I said, no. And he insisted. And then I've never seen this patient again, he was lost for follow-up.
Dr. Aman, I must remind you about the time, please.
Okay. This is a 60-year-old male patient, female patient, also counting finger closed. This is before surgery. This is after surgery. This is also another patient before surgery. This is at the end of the surgery. This is the patient on the left-hand side before surgery and after surgery. This patient developed something strange, which is this whitish lesion temporal to the disc and over the macula. It was a fibrinoid syndrome, fibrin collection. I did nothing. I gave him a steroid, and then this is the end result, and his vision improved. In conclusion, partial vitrectomy is a complication of advanced proliferative eye disease, a safe and rewarding procedure, proper patient selection, proper pre-evaluation, pre-op evaluation to predict the prognosis. When surgery is indicated, the earlier the intervention, the better the prognosis. Thank you very much.
Thank you very much.
This is on case which is a Roman city, one of the still existing cities at the north of Jordan. I advise
Right.
you to visit.
Thank you. May I
Thank you.
now request Professor Dawood Saab and to kindly in front of the stage to honor Muhammad Al Amari, please, with the shield. You've got it? You've got it. With the shield for Aman Madanat.